So, Adriana, tell us, why is coagulopathy in major hemorrhage such a problem?
So I think it's a really important part of what we see in our trauma patients. So often our polytrauma patients, the cohort that we tend to treat on neurocritical care, are patients with multisystemic injuries, including major hemorrhage, traumatic brain injury, and other injuries that they've got. And when they are coagulopathic, it often complicates the care going forward. So specifically thinking, for example, about patients with severe traumatic brain injury, when they become coagulopathic, it makes their care or their treatment much harder. So what they need is ICP-directed therapy, and we can't do that without them having an intracranial monitor in, which is inserted by the neurosurgeons, and it's literally a screw that they put into the head and then a wire that drops into the brain parenchyma. And if these patients got an increased risk for bleeding because of their coagulopathy, they will either then delay doing the procedure until that's corrected, which means that we then delaying that directed therapy that we would like to give these patients. Or if they go ahead and put it in whilst the patient's coagulopathic, they've got a much higher risk of forming a bleed because of that wire going in, worsening their traumatic brain injury. So just in that small example, if people correct the coagulopathy early when they come in, just that little bit will improve the care going forward for these patients. So paying attention to this can definitely make an outcome difference for our patients going forward.
Thank you.
Have you been involved in any cases where blood product resuscitation could have been better had we known what the patient's coagulation profile was?
Yeah, a few times, definitely. But I would say it's quite rare in the emergency department, because those patients that get a major hemorrhage protocol resuscitation are the ones to get moved out of the ED relatively really fast to either theatres or to critical care. So it's often the consequences of coagulopathy are felt after they've left the ED down the line. But I do recall, for example, I remember a guy who had a mild to moderate hemothorax. He got a PAC1 resuscitation and he stabilized out, got through a scan okay, and then he was brought back. And because he wasn't terribly severely injured, he stayed in the ED waiting for a level 2 critical care bed for a couple of hours. We didn't check his clotting. Well, the samples were sent, but nobody looked at them. He then rebled because he was incredibly deficient of fibrinogen, and we had to resuscitate him with another major hemorrhage activation all over again. And I do recall a vascular surgeon describing a patient he treated for a AAA successfully, but he described their blood as like Ribena as he was operating on them, and that led to consequences with oozing post-surgery.
How could we do this better?
So it's crucial that we know when a patient is becoming coagulopathic. And the only way to do that is by sending serial samples for clotting and for platelets. Up till now, we as a team have been collectively pretty poor at doing that. And that's because we're focused on other tasks. We're focused on the actual process of resuscitating the patient and on the task of moving the patient, transferring them to a destination like theatres or critical care as quickly as possible. But the trouble is that because we don't check clotting samples, we don't see the coagulopathy evolving, and we're not able to correct it. What we need to do is to send regular clotting samples, ideally after every pack of major hemorrhage products that we use, but also, again, when the patient has actually stabilized out and doesn't require any more resuscitation. And then secondly, it's equally vital that we check those results and discuss with hematology a corrective strategy if the patient is deficient in any products. So what we need to do is send a clotting sample and a full blood count for platelets after every pack of major hemorrhage products is used. And also we need to send clotting and platelet samples after the patient is stabilized out.